Um, I see the recording has been running for a while already. It's captured all our chit-chat. Good afternoon, everyone, and welcome to another seminar in our series from our Department of FaCE. We welcome you. Today I want to welcome the speaker, Wesley Craig. Wesley is a lecturer in the Division of Emergency Medicine. The topic he's going to be talking about is developing a domestic violence competency framework for emergency care providers. And he will probably talk about this, but this is from his PhD work, which he has submitted very recently. And we are looking forward to this. I'm quite excited. I fondly reflect on a recent seminar in this series by Sarah, etc. And I'm looking for similarities, and I'm looking for overlap and patterns to try and understand our next moves always and our next steps. So please engage. Keep the questions for the end. I'll collate, if there's questions in the chat, I'll collate it. And with no further ado, let me hand over to Wesley. Thank you very much.
Awesome. Thanks, Clint. Hi, everyone. Good. Yeah, I actually don't know what more to say introduction-wise. I'm Wesley. I'm with Division of Emergency Medicine. I'm a emergency care practitioner by background, having worked in the Western Cape Emergency Medical Services for a few years, but as a joined as an operational paramedic and as a lecturer. Yeah, so master's and PhD looked at the emergency care provider approach to domestic violence, specifically within the out-of-hospital environment. So I'll leave it there for now. Cool. Just as a quick note, the presentation is based off the insights gained through the PhD in forensic medicine. The thesis was submitted quite a while ago, just waiting for final examiner input before I can move ahead with it. This was supervised by Professor Lillian Arts, Prof. Lorna Martin, and then Dr. Navindra Naidu. I just need to point out, this is as by way of a brief content warning. The presentation does touch on a heavy topic of domestic violence and other forms of interpersonal harm. So what I describe might be unsettling. It may resonate with you, but in your own experiences, professionally or personally. And I do invite you to take care of yourself during the session in whatever way you need. That might mean stepping out, might mean just ignoring me, or just letting words wash over you. Yeah, feel free to use for any mechanism that you do to feel comfortable. While mentioning that, the topic is intended to be slightly uncomfortable. I feel like that generally gets the message home. So discomfort is part of the conversation, and it does signal that we are maybe touching on something quite important. Yeah, so I'll leave that there. Great, so I'm gonna show you a bit of how naive I was when joining emergency care as a young person. So these are pictures taken from operational time. And this is sort of what we were expected going into emergency care. So joining emergency medical services, starting to study, looking at a lot of trauma, whole bunch of car accidents, weird and wonderful things, overdoses, MIs, dysrhythmias, all very dramatic resuscitations, gunshots, stabbings. Yeah, harrowing, chaotic, traumatic, definitely in their own ways. But despite their messiness, I would argue that the edges are generally quite clear. There's usually quite a clear role for emergency medical services. There's a great assessment to perform. There's tons of different acronyms. There's really beautiful protocols and decision tools out there. The treatment is clear. Disposition's pretty clear most of the time. And I'm using that heavily in respect to what I'm going to talk about later. And we typically know where we stand when managing cases like this. But unfortunately, not all emergencies are quite obvious. Not all of them look like this, and often aren't the ones that we end up talking about at the end of a shift. So there are some things that typically make us uncomfortable, and then we sort of just move on, hoping it doesn't happen again, and hoping that, that maybe you aren't the one to have to deal with that. So just to slow things down a bit, we can compare those previous images with a little scenario. So an ambulance is called to a suburban home where they find a 34-year-old woman, Esme, with a black eye and several contusions to her arms. Early in the evening, she had called a neighbor she asked the neighbor to call EMS. When the crew arrives, she insists that everything is fine and explains that she just fell. Despite visible signs of repeated injury, she refuses care and denies that her partner, who happens to be an armed security guard, not at the moment present, has harmed her. She remains adamant that EMS providers should leave, and she does not want to discuss her injuries. She gets increasingly defensive when asked about her partner, stating that it's not your business and she doesn't want any trouble. So, yeah, things might feel a little bit different. The injuries are potentially very clear, but the explanations don't add up. She's refusing care. The atmosphere feels a bit heavy, feels very uncomfortable. And now you're caught in this weird nexus of professional duty, patient autonomy, and then patient well-being. Protocols definitely don't give us any neat answers here. And if you're thinking about healthcare providers within any setting, pre-hospital or in hospital, massive patient volumes, burnout, potentially PTSD, 2:00 in the morning, it's freezing cold. This is a very nice and clear patient refuses transportation and treatment, sign the form, and then you're off on your merry way. And there's probably almost 1,000,000% not going to be any repercussion for doing that. However, the discomfort remains, and there's the potential that this patient will more than likely reappear either within EMS, primary healthcare, district, tertiary level hospitals, or even in forensics later on. And these aren't rare cases, they aren't isolated. So I'm going to leave you with that story, and then we'll touch on a few things that we should potentially agree on. So what we know is that domestic violence is not just a private concern, it's rather a human rights violation. It's a profound public health concern, strips people of their freedom, their safety, their dignity. It affects every community, every demographic, though it must be said that women are disproportionately the victims and men are disproportionately the perpetrators of this act. As mentioned, it's a major public health burden. The injuries don't just end with physical injuries. It's often, for the most part, not physical injuries. It's long-term psychological, potentially financial, social scars that are enacted. There's higher rates of depression, anxiety, substance abuse, suicidal behavior, unwanted pregnancies, sexually transmitted infections. So this touches on basically every aspect of healthcare that you can think of. Within South Africa, the picture's a bit more stark. Police trust is at a 27-year low. Femicide rates are about 5 times the global average, and that's femicide being defined as women killed for the very sake that they are a woman. Not just someone being run down by a car, which makes it a bit more complicated because the police detectives then need to determine causality and the relationship of the perpetrator with the victim after the death. So that does become a bit more of a detective issue, and femicide rates are dropping because of that, and it's likely due to the burden on the detectives themselves and their caseload, and them not making that connection later on, and therefore doesn't get defined as femicide. So we know it's rather not just a series of isolated events. It's something that is tangible. You're feeling it in every aspect of the healthcare system. These patients do reoccur, they do resurface. They absolutely have more admissions to hospital. They come to the emergency care to ECs more often, they reappear to EMS more often than patients not experiencing any form of domestic violence. This is probably, I don't want to make it too funny, but this is probably the most dramatic picture. the number of emergency EMS qualifications within the country at the moment, just to give you some context. So the basic ambulance assistant is a 4-week short course, which was discontinued. And that is, along with the emergency care assistant, which is a 3-month short course, that forms the bedrock of emergency care within the country. About 80% of EMS providers that you see riding around in ambulances as we speak are basic ambulance assistant and AEAs. There's 6 different professional board for emergency care registrations within the HPCSA. You can see that the BMC and the BTEC are 4-year qualifications. So EMS training encompasses everything from 4 weeks to 4 years of training, various levels of scope, and procedures that can be given, or that can be performed, and drugs that can be administered. At the moment, only 3 qualifications are currently active. The 1-year high certificate, the 2-year, soon to be 3-year diploma in emergency care, and then the 4-year bachelor's qualification. The point I'm making here is that out of the 10 different qualifications you have available, that one that we don't often talk about is operational emergency care orderly, which is a military medic qualification. Out of all of them, there's never been any standardized training, educational intervention, or purposeful curriculum integration of domestic violence education into any of the curricula that you see in front of you. Okay, so what does the law say? So the Domestic Violence Amendment Act 14 of 2021 added something from the 1998 Domestic Violence Act, the original one. That original Domestic Violence Act was quite a profound move in legislation. The first time domestic violence, with a variety of different definitions, actually entered legal parlance. But it was, for the majority, mostly a police and a court issue. A whole bunch of obligations for SAPs and for how victim survivors can apply for protection orders. The big change, along with broadening of the definition of domestic violence to include coercive control, spiritual abuse, was the introduction of this term functionary. And that is someone who must report a belief or suspicion of domestic violence to a social worker or to SAPs, that any vulnerable person, so that's a child, a person living with disability, or older person may be experiencing domestic violence, and they should conduct a risk assessment and then refer to further services. In this case, functionaries are defined to include medical practitioners, healthcare personnel, social workers, officials in the employ of public health establishment, and educators and caregivers. So this is the first time, only about 4 or 5 years ago, this actually only came into place in 2022. So about 4 years ago, that healthcare providers are actually named within the Act to report domestic violence, but only within those 3 categories of child, person experiencing, older person, or person living with a disability. Unclear on what to do with individuals experiencing domestic violence who do not fall within that category. Okay, so this sort of speaks to the concept of screening, and when do we screen, and what do we do with that information, and where does that information go? Okay, from the HPCSA, booklet 8 speaks to reproductive health. And yes, there is guidance from the HPCSA. No real clear guidance or evidence on how this was taken up, if training occurred in this, what the current adherence to this booklet is within the entire healthcare sector within the country. But you are supposed to ask gently about violent or controlling behaviors and believe the patient's response. You are supposed to assess risk, conduct a risk assessment. Unclear what the risk assessment looks like and where you should hand it in, especially if considering that the cases where it isn't a child, it isn't an elderly person, or it isn't a person living with a disability. Provide supportive care, unclear what that means. Document any evidence of abuse on a domestic violence examination form. I haven't seen that form before. I don't know where to find it. I'm not being facetious. I literally, I can't find it when you look for it. Then he's supposed to inform patients of their rights, services, legal remedies, including how to obtain a protection order, when to report the case to police, explain the implications of it. So that is excellent and that is good guidance. However, as you'll see in our stakeholder engagement sessions later on, it's unclear what is realistic and how much information a victim survivor can actually take in at a point of crisis. And then finally, refer responsibly to appropriate resources and identify the support system. Again, unclear. So it's great that it is there. There's something that we can build off of, but it's not really clear on how to approach that. So from my perspective, from the approach that I took, looking just at the pre-hospital response, the PhD looked at a scoping review, looking at international best practice, local and international, on how EMS should approach and respond to domestic violence. We then did interviews with victim survivors of domestic violence themselves. We then did a consensus-based process, speaking to stakeholders across law enforcement, mental health services, social services, EMS, and in-hospital providers. And then finally, we drafted a competency framework to help guide the process. Yeah. From the victim survivor's perspective, so there were 20 victim survivors that I spoke to within a Cape Town Women and Children Center. They're all adults, and they're all basically asked about their experience in encountering or engaging with acute care services, both pre-hospital and within the emergency center. And we get quite a full picture, or a more full picture of what they're experiencing and why they didn't want to approach formal services. Many of them live with a deep, potentially generational entrenchment of violence within the community and their family life. It's often not a single event. It's almost never a single event. It's a patterned environment. There's deep physical manifestations of violence, which absolutely preclude someone from seeking help. In terms of community, a lot of them spoke, and I think this will speak quite nicely to Sarah's talk. A lot of them spoke about the idea of just violent communities themselves. This one specifically, community. This is how our community treats any type of violence. You beat your husband, he deserved it. If your husband beats you, you deserved it. There's no question. If you beat your children, they deserved it, because you need someone to take your stress out on. And then often in more violent communities, children are growing up with violence within the relationship of their parents. But there's gunshots outside and there's bodies lying on the floor and there's brain matter on the street. And you're seeing that in your formative years. Coming home and seeing someone get slapped or pushed around probably doesn't look that major compared to what you just witnessed outside. And that gets entrenched and it becomes absolutely normalized. In terms of their encounters and engagement and experiences with acute care services, a lot of disbelief, a lot of violence minimization, this deep concept of institutional betrayal, both from the police officers that they're seeking to get protection from, or get protection as a service from, their encounters with nursing staff, with doctors, with ambulance, EMS providers. A lot of it seems to come from this idea that the resources is constrained, and they use this as an excuse for impatient abruptness or just apathy and just, it's you again. And that victim blaming absolutely made it worse for them to come back. So they'd rather just deal with the violence longer than have to deal with someone not believing them. Or worst case, the provider or the law official actually taking the perpetrator side, because they're typically quite charming, quite charismatic, usually very well known. And it is possible for that story to just get twisted and turned into something where the victim then becomes a victim again. So from a survivor's perspective, there's often very little to gain from disclosing abuse. If the person they disclosed it to does minimize them, does judge them, does disregard them, and in this case, disclosure doesn't feel like safety, it feels like just further harm. So yeah, this changes quite a lot of things when it comes to that hard and fast rule of asking every potential victim survivor their experiences. That almost comes into a conversation around, it's not potentially what you ask, but it's about how you ask it and what's the context and what you're going to do with that information. It comes into the idea of potentially the victim survivor or the patient you're dealing with is not minimizing their own abuse and is not being stupid about not seeking the or accepting the help that you're offering because they don't understand. It might just be an absolute learned behavior that they are doing the best that they can. This is how they protect themselves. It's worked before, it'll work again. Having someone in a uniform tell you what to do or to just leave your partner is absolutely going to make things a lot worse. There's loads of reasons for them not to want to leave the relationship. There's financial barriers, there's cultural, societal, even familial pressures to potentially stay within the relationship. And then it often gets disregarded that love isn't in the picture as well. A lot of the victim survivors still love their partners. So we took that information along with the scoping review, shared it with stakeholders, and got their perspective. These are stakeholders across nursing, emergency medical services, family physicians, emergency consultants, social workers, detectives within SAPS. And we came across 6 themes, both in the qualitative space and then also in the actual practice recommendation development. And I'm not going to read through all of these. There's quite a lot. I wasn't sure how much information to put into this thing. But there was conversations around provider and scene safety, the idea of role ambiguity. Where does the responsibility begin and end for EMS versus a social worker versus SAPS? Because they're all working in the same sort of area, but within different timelines, and there's often no real overlap. So no one else can see what each other is doing. There's the idea that EMS, the teaching, the current training and historical training practices have been largely focused on the biomedical model. Not a lot of emphasis placed onto topics like this. And then there's a hesitancy to even bring up the conversation, because what are you going to do with information if someone does disclose that they are being abused? What are you going to do with information? Where are you taking the patient? Who are you going to call? What information can you realistically give to that person? And there's a lot of hesitancy to even approach that. And if there are questions, if providers are potentially given a list of questions to ask, it really cannot be seen as a simple tick sheet process, but that's going to be way more harmful. That's going to seem insincere. You're likely not going to end up anything useful from that. And then you don't have to read through all of this, but it's just a concept that it's context dependent as well. So if you're working in a system which doesn't have a lot of support in it, say the social worker mentioned in the Eastern Cape, there's certain districts, certain areas where there's literally no support, no referral processes to go. So by going around willy-nilly offering people waving pamphlets and calling this, labeling it as intermittent violence, you can't guarantee that's going to do anything useful. Even just taking the patient away for the day, driving them off to the emergency center, just for the sake of getting them away from the partner, that can actually escalate the violence as well. Then we spoke to SAPS as well with regards to their assistance on scene with EMS. Massive shortages of staff, of vehicles, obviously dealing with a very high crime rate. They're understaffed. EMS is very understaffed as well. Population has increased dramatically. The number of ambulances within the public sector has stayed fairly stable over the last few decades. So the really, all of this just adds pressure to the interaction that the provider might have with the victim survivor. And then just conversation around both training and then the patient handover from the paramedic or the emergency care provider that might have seen everything on scene, trying to relay that information to a physician or in hospital, in facility provider, as they've potentially been able to see all of the information that's on the scene, the things that don't always get documented. And just the clinical forensic physician just explaining that she can feel quite sympathetic because you walk this road with the patient and then now they're going to a place where they're just another number, a folder, and they have to wait for potentially 12 hours sometimes to be seen. So from this, there were the actual practice recommendations that came out of it. So the recommendations were, I'm not going to show you all of them, just an idea of what it looks like. So in this case, always consider the possibility of domestic violence as part of normal patient assessment. There's a rationale, there's a section on whether across the 4 iterations of the Consensus Development Conference, whether it was a concept that was saturated, and then if there's alignment with the WHO and NICE guidelines dealing with intimate partner violence. So this was done about I think 60 or 50 something recommendations about moving the patient to private space, conducting a risk assessment if appropriate, and then the domains around immediate safety planning and risk mitigation, understanding. Importantly, this came from the stakeholders that you cannot, even though the HPCSA says you must do a full risk assessment, you must provide the patient with all the information. Physically, that is not realistic within that narrow interaction with a victim survivor within their house or within the ambulance before you get to hospital. It's physically not possible. And then where does the responsibility lie, and where does your your role begin and end in that case? So it is quite useful to see realistically on the ground, and speaking to all the providers that would be handling or potentially encountering this patient in their own professions, what they think is realistic. So that was just the practice recommendations. From there, we went on into the competency framework development. And for this, I used BAT's 6-step model for developing competency frameworks in the healthcare sector. And this asks you a whole bunch of different questions around who are the intended stakeholders, what is the scope of this, what are the limiters, what are the delimiters of a competency framework that's like this. We then identifying context of practice, so that's what the scoping review did, see what everybody else is doing. What is it that EMS's role is when it comes to domestic violence? Are we simply just the wheels? Is there something else there? Exploring practice. So this came in with both asking victim survivors themselves what they would like to experience from EMS, what their current experiences have been, what they would like to see, and then from the professions themselves on what is realistic. And this was all developed into set of competencies which spanned across, and I use there's a lot of theories, Green and Levy and their embedded competencies model. So looking at common core competencies, which are labeled foundational, then occupation specific, then activity specific. So if, for example, we wanted providers to accurately document the patient encounter, there'd be communication in a written form as a foundational competency, and then it might be a bit more specific as we move on into documenting through the screening process or the risk assessment process, where it becomes a bit more activity specific. And from that, we developed the competency framework across 8 different domains, starting from provider recognition over to system and policy changes. Okay, so just an extract of what some of the competency statements might look like. There is significant overlap, as you would in any process like this. Some competencies are knowledge and attitude, or are knowledge and skill. The levels might also span beyond foundational to occupation specific. And then there's a small description of what it would look like if you were to say this person is competent in doing this. And then the last one is just about where exactly I can pinpoint where the evidence came from to support this recommendation or this competency statement. So this is done across the entire encounter, from even just the provider's attitude towards domestic violence before even seeing the patient. Just the actual understanding of what it is, because if you don't know what it is, you can't identify it, and if you can't identify it, you can't refer it, or you can't manage it. So it moves from quite broad to quite specific. I won't show you all of them, but you're welcome to shout and ask. A lot of it came down to knowing where the limits are. So you can recite the entire Domestic Violence Act to a victim survivor at a time of crisis. Whether the information is going to go in or not, you might feel like a champ because you covered everything, and you've theoretically given that survivor the best shot because they've gotten the most information. But is it valuable? Is it actually useful? Is it contextual? Is it trauma informed? Is it a different conversation? So it's about where that fits in and how to even navigate that conversation. All of these fit together, nice pretty diagram, using Bronfenbrenner's ecological systems theory. And you can see the micro, when we talk about the micro ecosystem, it's referring technically to the patient and the provider interaction. And you can see the vast majority of the competencies fit within that that small microsphere. The next one is MESA, which speaks more to the systems. So that's where referral falls in. The like organizational level, and then domain 8 in the macrosphere speak to system and policy changes. So the vast majority of the recommendations, the competencies do fall within the micro, and then the supporting sort of structures would speak to referral and system and policy changes. Almost done. Okay, so what to do now? So you might have noticed that the EMS is sort of biased towards what we find important, what we find the easy to do. For the BMC, for example, we spent 4 years just learning emergency medical care. A lot of the emphasis is on the absolutely critically ill patient, which we know already, specifically within the Western Cape, is maybe 3 to 2% of all of the patients that EMS sees. The vast majority, 80% of them that are transported. This is one of our PhD students, Faisal Binks, and supported by Willem Stassen, found that the 80% of EMS transportation cases don't receive any medical care. Couple of different potential reasons for that, but one of it might be that it's not that the cases need medical care. It might mean that they need transport, and the vast majority of those could potentially be cases which don't easily fit within the biomedical focus of a patient that's critically ill, that's dying, that's bleeding right now, that you can't even have the concept of an emotional engagement or a more empathetic engagement. The vast majority of these cases are just sitting in an ambulance, varying levels of provider engagement with topics that don't speak to what we classify as easy emergencies. So there is quite a lot. There is definitely a space that we can look at improving that response. Potentially the first shift when it comes to domestic violence specifically is to reframe what success means. And it potentially isn't forcing a decision or the patient going in the ambulance and just leaving the abuser tonight. It's not potentially a protection order being processed. It's not about them leaving and potentially coming back tomorrow. It probably looks a bit more quieter than that. It probably isn't supposed to feel like we're feeling like the rescuer in that moment. It's likely more the fact that you're present and you can recognize and believe and listen to the victim survivor as they tell you the story, where you're able to balance autonomy, well-being, and duty. You're able to communicate your competence in that you might understand that someone is going through this specific situation, but you're also able to show a behavior and actually reinforce to the patient that you're understanding them and you are hearing them and you are going to act in their best interest while still not over-promising and still telling them exactly where your responsibilities lie. And then assisting them in navigating the system, which is completely not victim-friendly, especially when it comes to the legal system. And then it's also noticing our own discomfort. If you're feeling incredibly uncomfortable about handling cases like this, maybe lean into it a bit and resist the urge to withdraw and disengage. Because that's typically where all the good things come out of. That discomfort is absolutely the data. Yeah. So I think that's the main part of what I'm talking about. There's a lot that I can dig into. One of the value propositions that came out of this whole thing was that a lot of what was uncovered through the stakeholder engagement, through what the victim survivors told me, isn't brand new stuff. It's not state-of-the-art, cutting-edge interventions. It's really things that we are doing already, and it's, for the most part, it is taught, but it's fragmented. If someone is good at managing a domestic violence case, they're probably good at a whole bunch of other things. They're probably good at de-escalating the depressed patient, or identifying child abuse, or correctly documenting forensic crime scenes if they're the first on scene. They're probably good at all of these different competencies, start pulling everything together and having a narrative that flows, which is slightly disjointed at the moment across all the different qualifications. Yeah, so I'll leave it there. I'm happy to have any questions. Thank you.
Thank you, Wesley. That was fantastic. And every time I listen to you, I learn a couple of things more. They're really, really insightful. So much for us to do and think about. And yeah, I'm quite eager to hear the questions. I've got a few questions here as well. Let's open the floor for comments or questions. While people are,
thank you, everyone. Cool.
thank you. Everyone understands everything, and there's no questions. No, I've got a couple of questions and comments, but I also have a little reflection, and I started talking about it before this. Sarah Bramcroft had spoke about violence in the community, how they perceive it, how they live with it, how they internalize it, and then how all these conversations are massive gaps in how we as healthcare providers are trained, how we engage with patients. We've been trained to be often paternalistic and biomedical and so on. So there's a massive gap. But what I'm seeing is a pattern FaCE. We've always trying to understand, are we doing more than our goal to do more than the sum of the parts? And I'm seeing little bits of a pattern forming. So all these gaps, we spoke about the curriculum, the undergrad curriculum reform that's happening, kind of under FaCE's guidance as well. And I think there's just massive opportunities. These gaps, FaCE is probably the best positioned to address, to understand it, number one, to make sense of it, and to address these the gaps and challenges. I just got a little, I digressed a little bit, but I really see pattern ways. I don't know if you want to comment on that. So our unique, I'm talking about FaCE, primary healthcare, family medicine, EM, sports, palliative care, and how we are, the values and the principles that we have, we're community-based, we are, we primary healthcare approach as our core. How do you see our role? Sorry, it's a bit of a difficult question, but how do you see our role with these uncomfortable topics where there's clear gaps in our training?
I'm sure that there's the gaps in the training. There's the workplace environment. There's the public perception or individual perception of what isn't domestic violence as well. And we can stretch it across interpersonal violence. Yeah, they could. point in almost any direction, you'll see a gap and you can try and fill it. It almost seems to be something that needs to work within an ecosystem and starting in small niche areas, or not niche areas, but starting in pockets of patient flow. And that's typically where things might start to work. You know already the healthcare system typically works off of WhatsApp groups and not through emails. It's relationships between different healthcare providers that keep things flowing. It's why it's so problematic potentially, because like transplanting policies and guidelines from other countries into here doesn't work. The systems don't speak to each other. Having a national guideline as well, which I considered before, probably wouldn't land either. It's so specific to where you are and what resources are available. It probably would start with the individuals within that value chain just speaking the same language. And if you were to troubleshoot and start off with like just simulating the idea of a patient presents like this, where do they go? From an EMS perspective, I can't find anything specific that says that a patient that's experienced domestic violence that isn't in actual need of medical treatment, I can't find anything where it says they're supposed to go to a clinic or a busy emergency center, and that's where they're supposed to go. There are civil society organizations where the patient would absolutely be welcomed. It's just not built into the process of dispatch and of just the patient flow. It's not built in there. I would try to challenge that idea that patients absolutely have to be taken to the same place every single time, despite that it's not there in their best interests.
Yeah, thanks, Wes. And I really think FaCE is uniquely positioned. So all of these challenges sit at the intersection between the providers and the patients or the clients within that community, because of our generalist principles and values, our generalist lens that we come from, because of our primary healthcare approach. It sits within. We are best positioned to tackle these, and I'm quite excited. I've got two things. I've got Pat, your hand is up, and then I wanted to give Leonard a few minutes to just reflect as well. Thanks, Pat. And then Leonard.
Hi, everyone. I'm Pat, one of the site facilitators. I've recently received the form that you spoke about, Wesley, the form from social development, the one that speaks to child neglect or child abuse. And I was looking at it because I was thinking of a project that we can actually do to raise awareness as to where to send people when they are facing those challenges. Now, the problem is our students do not have the capacity. I'm not sure whether the capacity is the right word to be training people on how to deal with these things, because it can be very traumatic, and I do not want to create a situation where students are going to find themselves in a space where they are emotionally charged themselves. So I don't know if there's anything that can be done to ensure that our students at least are supposed to work or navigate that space. Thank you.
Thanks, Pat. Thanks for the question. I think the easiest option would be within specific areas. We call them catchment areas or referral areas for specifically civil society, and then also for Department of Social Development, where their social workers are, because that's often the case where these patients need to go and need to get further support and care. I would probably not immediately recommend that everybody just gets taught in how to engage this or how to screen patients in a universal manner. WHO doesn't recommend universal screening and universal education because there's no evidence that it works and it receives. There's no evidence that the patient actually gets. The patient's actually safe at the end of the day by everybody being asked the same question as they walk into an EC or as they walk into a specific clinic. And there's this potential harm that so there are disclosures, but there's no resources to support the patient once they're disclosed. And now you're just reinforcing the fact that there's this institutional betrayal, that you're asking them to be vulnerable and then saying, cool, cheers, thanks for that information, noted, and then where do they go from there? So it would need to be a bit more context specific about what you're wanting. What is the objective that you'd like the students to be able to do? Is it about the concept of just believing the victim survivor? Because that's probably the most important part, and someone actually understanding and just taking a patient's word at face value and believing them, because that's pretty much 100% of the time it is true if they're telling you something like that. And having that emotional or that empathetic response of just believing, that's a great first step in just changing the psyche of victim survivors that have been through the ringer before, potentially through the legal system, which is absolutely brutal, through dealing with SAPs, through other healthcare providers that maybe haven't had that that education. So a good place to start would just be doing that first, and then understanding all the referral opportunities within a given area, and not just obviously parrot fashion learning everything. Specifically areas where they don't have Tutuzela care centers 15 minutes in every direction like Cape Town seems to have.
Wesley, I can also reflect that from a facility point of view. Our health system is designed for office hours only. It's one of the big problems with the health system. All the resources, all the people are there from 8 to 4 on a Monday to Friday, and everything that happens afterwards. So when it comes to access to social workers, even occupational therapists and other departments, Department of DSD, etc., it is a big challenge, even from a facility point of view. When you have a social worker office hours, after hours, it's even more difficult. So there aren't the link between the health system and DSD and so on. The acute link is almost non-existent. It takes a lot of effort to make that link. It is possible, but it's very fragmented. So there's a lot of work to do with linking between the departments, but also understanding what resources we do have from a CBS point of view. So which NGOs, NPOs can they link with? What is their capacity? So as Wesley said, there's no point in screening if we can't link or there's no action at the end, because then we're doing more harm. The problem is we don't always understand the capacity of the NGOs and NPOs, the CBS, the community-based services that we do have, whether it's in our health, in the Department of Health or in DSD. So I think there is also a gap in understanding what we can do. And it's so good to talk about this. Jackie, can I quickly give to Leonard just to explain his, unless you want to reply on what we're discussing now, Jackie, is that it?
No, it's fine. Leonard can go.
Okay. Yeah. Leonard, do you want to quickly talk about what you have? Hi, welcome.
And then do you still meet today?
Thank you. I'd encourage everyone to look at the poster that I added in the chat. I saw this poster, I think at least 15 years ago, and it was educational for me because there were so many subtle forms of abuse that I didn't even recognize as abuse. And that's the number one. Number two, which is actually number one, is that talking about domestic violence, domestic abuse is actually a taboo subject, not only in our society, but across the globe. It's something that people don't want to talk about because most people do face domestic abuse of some kind, and it's across the board. It's not just in certain areas and certain communities. So yeah, that's really, I mean, Clint, you asked me to comment. That's my comment, is that we need to look at also addressing the
100%.
The taboo around discussing it, which is why, if I'll just conclude very briefly, which is why a poster like this we don't really see, and which is why it also took me so by surprise that I kept this poster. Yeah, thank you so much.
Thanks so much, Leonard, and so spot on. if the health providers don't know how to respond, the med students definitely don't know how to respond. The EMS and then the nurses, especially in the cadres that have the lower training duration, like you say, Wesley, definitely then don't know how to respond or how to react or what to do with the information. And the community members probably know even less. So it filters. We have to address it at all those levels as well. Thank you, Jackie. Over to you.
My point actually links very well with that. Many, many years ago, I actually did my master's on looking at the impacts of trauma on emergency service workers. So Wesley, I mean, it was such an interesting presentation. So yeah, thanks very much. And I can't wait till I'm sure you pass it and then we can start talking about, yeah, potentially doing some work together, because it's an incredibly interesting and important area. I just was wondering, in terms of the interviews, qualitative interviews that you did with emergency service workers, frontline workers, we picked up quite a lot of vicarious trauma in general with emergency service workers themselves, from what they had been exposed to, the trauma of their work, of what they were being exposed to, and also their own personal trauma journeys, which, as we know, if South Africa has such a high domestic violence rate, we know that our frontline workers have more than likely been exposed to that themselves. And that also led to some of the conversations around some frontline workers actually being the perpetrators of, making coping mechanisms with making use of substances or alcohol or whatever, and then that resulting in violence. And when I was working at the trauma center for survivors of violence and torture, we were working on a strategic plan for the city of Cape Town. If there was a large-scale emergency in Cape Town, how to develop a large-scale strategic plan, and to operationalize it. And part of that was actually, the first line was actually working directly with frontline workers, because if you can access people's individual traumas and they talk about it and they get on board with, I remember interviewing some of the emergency service staff, and they would come in initially like, this interview, I've got like 15 minutes, like I don't have much really to talk about, but I'm happy to meet with you. And like after an hour and a half, trying to actually say, okay, we need to wind up this interview, because as soon as you start unpacking that a bit, the emotion that comes out of just the toll on our frontline workers is just phenomenal. So I was just wondering if sorry, that was a very roundabout way of getting to my question, did that come out at all of how people are coping at an individual level, trying to, as a traumatized person, trying to support other traumatized people is extremely hard. I wondered if that came out at all.
Yeah, thanks for that, Jackie. And yeah, absolutely keen to touch base with you. Yeah, I didn't have one data collection session where there wasn't someone that approached me afterwards and said, like, listen, it is, it's not just a professional experience, it's personal as well. That being said, there's likely that there was a selection bias as well, and those that were interested in the topic would have approached me as well to join the research. So I'm not blind to that as well. But absolutely, would be really a bit tone deaf to think that professionals themselves aren't victim survivors, or potentially aren't perpetrators. We see that in SAPS all the time, that a lot of murder suicides are from SAPS members themselves, that femicide cases are from SAPS members. So it's rife, it's everywhere. And I would say that in the same case that we're asking healthcare providers to be brave and ask the question, if their system, if their workplace, if their family, if their community is not responsive to their needs, how responsive should they be to others? What is a realistic or reasonable expectation in that case?
Especially, so as you say, when you talk about culture, there's also culture at work, isn't there? So, and the culture within the police, SAPS, or emergency services, people don't want to reach out for counselling that they possibly know they need, because they don't want that on their record or whatever. So it's yeah,
Yeah.
it's really, I like the fact that you used from Brenner, because I think, yeah, systems approach is, yeah, a really great one. It's a massive issue. Yeah, thanks.
Thanks, Jack.
Thanks, Jackie.
Yeah.
Thanks, Wesley. We've
Always
got
leave
time
these
for one more.
conversations with more questions.
Yeah, we've got time for one last comment, and then we'll close this fantastic session. Good. That's it, Wesley. Thank you very much. Really informative,
everyone.
really great, and lots of work that lies ahead for us, Wesley. Thank you, everyone. Have a good evening, a good afternoon. Bye-bye.
Awesome. Thanks, everyone.